Hello, everyone. Thank you all for joining me on this call to dissect pharmacogenomics in Marfan syndrome. I have no conflicts of interest to disclose. By the end of this presentation, participants should be able to describe the pathophysiology, presentation, and diagnosis of Marfan syndrome, discuss medications to initiate and avoid in patients with Marfan syndrome. So Marfan syndrome is a systemic connective tissue disorder that progresses with age. An underlying causative factor is mutations in the FBN1 gene, which leads to decreased expression of fibrillin-1, which affects microfibrils and elastic fibers. More on that coming up. It is inherited in an autosomal dominant pattern, which means just one copy of mutated FBN1 can cause the disorder. A quarter of cases of Marfan syndrome are de novo, which means that the mutation is new in the affected individual. It is highly penetrant, which means that most individuals who inherit the genetic mutation will be affected, and has variable expression, which indicates that the severity and specific symptoms of the condition that can show up can differ widely among individuals with the same genetic mutation, even within the same family. The most prominent manifestations of Marfan syndrome are seen in the cardiovascular, ocular, and skeletal systems. While Marfan syndrome affects all ethnicities, variability in presentation has been seen. In European, Hispanic, and Asian populations, cardiac and ocular manifestations have been noted, whereas the skeletal features are primarily described in individuals of European descent. The incidence of Marfan syndrome is between 1.5 to 6.8 per 100,000 in European populations, which is likely an overestimation because these are older studies back when the criteria for diagnosing Marfan syndrome were less stringent. Prevalence data for other regions of the world is lacking. The FBN1 gene encodes fibrillin-1, and it's located on the long arm of chromosome 15. Identification of FBN1 genotype to phenotype associations is complicated because there is high inter- and intrafamilial variations in the clinical features. For the sake of time, I will skip over the different associations that have been noted in the literature, but they are included on these slides here for your future reference. The FBN1 gene encodes fibrillin-1, which is the major constituent of the extracellular matrix. Many molecules of fibrillin-1 link together to make long thread-like microfibrils, which make connective tissue strong and elastic and also help control growth and development. There are two types of microfibrils. There are flexible microfibrils, which support stretchy tissues like blood vessels, lungs, skin. There's also the non-elastic microfibrils, which provide structure in our bones and our tendons and anchor the eye's lens. Weak connective tissue leads to unstable skeletal structures, overly flexible joints, and frequent dislocations. Many fibrillin-1 microfibrils also have a second job. They store other proteins, keeping them inactive until they're needed to do their job. An example of that is TGF-beta, or transforming growth factor beta, which helps to control muscle and bone growth. When microfibrils don't form properly, the disrupted TGF-beta, it can result in tall and thin physique that we see in patients with Marfan syndrome. Speaking of which, for the more visual learners like me, this slide shows the major manifestations of Marfan syndrome. So we can see scoliosis or curvature of the spine, chest wall deformities, elongated digits, or arachnodactyly, as evident by a positive thumb and wrist sign. So the thumb sign is if you roll your fingers around your thumb, the thumb sticks out on the end. And the wrist sign is if you wrap your fingers around your wrist, if your pinky finger and your thumb can overlap, that's positive for the wrist sign. In terms of ocular features, the most common one is myopia or nearsightedness, and ectopia lentis, which is the dislocation of the lens. And the major cardiac manifestations of Marfan syndrome is thoracic aortic disease. The aorta is a highly elastic structure with greater than 50 layers of elastin and smooth muscle, which help to withstand the pulsatile blood flow that goes through them. If thoracic aortic disease begins, it begins as asymptomatic root enlargement. If that's left untreated, that can progress to an aneurysm. And then if that is left untreated, that can progress to aortic dissection, which can be fatal. There are two types of dissections. First is type A dissection, which is of the ascending aorta, and that is associated with a high mortality rate, and that's the more common type of dissection that our Marfan patients present with. The type B dissections, those are of the descending aorta that has lower immediate risk, but in the long term, it can have significant complications. The incidence of type B dissections is lower than the type A. So let's talk a little bit about diagnosis. The journey of accurately diagnosing Marfan has evolved a lot significantly since it was first described by French pediatrician Antoine Marfan in 1896. Fast forwarding to 1955, a classification of connective tissue disorders was established. Then in 1986, the Berlin criteria was introduced, which showed the first set of clinical criteria for a Marfan syndrome diagnosis. In 1991, the FBN1 gene was identified as the causal gene for Marfan syndrome, and this is when it was recognized that the Berlin criteria falsely allowed a diagnosis of Marfan syndrome in individuals that have non-specific connective tissue findings based on a positive family history, but they didn't necessarily carry the mutation that's present in other family members that were more typically affected. And to address this issue of overdiagnosis, the original Ghent-1 criteria was created in 1996. This had more stringent criteria to help kind of rule out some of the similar syndromes that are not Marfan. And finally, in 2010, this was further revised into the currently used Ghent-2 criteria, which places an emphasis on thoracic aortic disease. To use the Ghent-2 criteria, you can put your patients in two different buckets. So those with a family history of Marfan syndrome and those that don't have a family history of Marfan syndrome or their family history is unknown. So if we look down at our first column, if family history is positive, you need just one of the following to get a diagnosis. So ectopia lentis, systemic score of 7 or higher, or aortic root dilation, unless these are indicative of another connective tissue disorder that's related, like Ehlers-Danlos syndrome. Now, going to the next column, if family history is absent or unknown, then it has to be a combination of a few things to diagnose for Marfan. You can have aortic root dilation plus ectopia lentis, or aortic root dilation and an FBN1 mutation, aortic root dilation and a systemic score of at least 7 points, and or you can have ectopia lentis and an FBN1 mutation that's associated with aortic root dilation. It is important to note that a genetic test just by itself can neither confirm nor rule out Marfan syndrome, which is why we have to have those systemic features looked at as well, and looking at aortic dilation and ectopia lentis. So early diagnosis and intervention are critical because if caught early and treated, life expectancy of our Marfan patients approaches that of the general population. Medications that are available right now can slow down the rate of the aortic enlargement, but they can't really prevent it, which is why it's really important to catch it early before it has progressed to where the patient experiences significant harm. The 2022 ACC/AHA guideline for the diagnosis and management of aortic disease has a class 1 recommendation to treat these patients with either a beta blocker or an ARB at maximally tolerated doses to reduce the risk, to reduce the rate of aortic dilation. And it also has a class 2A recommendation for using both of them, both these agents, so beta blocker and ARB together. The guidelines also briefly, like all the way at the end, mentioned that emerging data is coming out about fluoroquinolone use and its association with aortic dilations as dissection as well. So looking more into that, I found that in 2018, December 2018, the FDA issued a drug safety communication that was warning about increased risk of aortic ruptures with fluoroquinolones in certain patients, and they specifically call out patients with Marfan syndrome and EDS. The gene reviews chapter on Marfan syndrome also lists medications to avoid, such as decongestants and excessive caffeine, which are interesting because both of those are not prescription medications, so widely available for people that may not know about their underlying Marfan and the risk that it poses. Also, triptans, and they also mentioned triptans to avoid, and for antihypertensive medication selection, to pick the ones that have evidence for efficacy and safety in the Marfan patients. So ARBs or beta blockers instead of like ACE inhibitors and calcium channel blockers. I believe those are okay to use, but when you're picking, they prioritize the ones that have evidence. This slide here summarizes the differential diagnosis of Marfan syndrome. Conditions like congenital, contractual, arachnodactyly, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, and hereditary thoracic aortic disease all have overlapping features with Marfan syndrome, but they also have key distinguishing features that may benefit them from that they have key distinguishing features that they can benefit from different types of treatment than the specified treatment for Marfan syndrome for the differences that they have. So genetic testing panels for genes that lead to heritable thoracic aortic disease, that's often the most broad because that incorporates all the genes. If you look at the bottom column with the altered genes, it looks at more genes, so it'll help you kind of narrow down the underlying genetic factor that's causing their disease. So it may not be Marfan, so we can target the treatment of those patients accordingly. And lastly, to summarize, Marfan syndrome is a systemic connective tissue disorder caused by mutations in the FBN1 gene. It affects multiple systems like the cardiovascular, ocular, and skeletal systems. Diagnosis currently is based on the Ghent-2 criteria, and there are recommendations for medications that can be used to delay complications like aortic dissection, such as beta blockers or angiotensin receptor blockers, noting that they don't prevent them, they just delay the progression of the dilation. And there are mention of some medications that could increase the risk of aortic dissection that should be avoided. And with that, I conclude the didactic section of my presentation. What questions do you have?